we are on the couch now with Fiona Bolden. Fiona's a GP from Raglan. Fiona, I'd like to chat to you about your experience with rural people and depression and suicides, because it is very much a real concern at the moment. What's your experience in your practice about dealing with people that are identifying people that are suicidal, because often people don't show signs of depression necessarily, do they?
No, certainly they don't. They can present with all sorts of things, and in fact usually in the farming community they're usually presenting with an accident or something acute which might be stopping them from working. But it all comes down to relationship really, and building up those relationships, which you, as a rural GP, if you've been there for a long time, you've often built that up over time. But in fact you can do that quite quickly as well if you actually ask the right questions. So usually if I'm interested in, particularly in farmers, how the farming is impacting upon their life, I'll start talking a bit to them about farming, finding out about what kind of farm they're on and how the current situation is impacting on them, and then start to pick up the other stresses in their life, for instance how that's impacting on their families and what sort of support they have. So it's about gradually peeling back the layers of the onion to see what's underneath it.
So how are you doing that in a 15-minute slot?
Well, you can sometimes you can just identify that there is a problem and think, well, actually, this is too big for me to deal with this all right now. But it may be that you need to review them again anyway with their physical problem that they came with, so you can bring them back to see you again. We have got some provisions to do that. For instance, if we think somebody has got a moderate level mental illness that they need management for, then we could apply to the PHO for a funded follow-up consult or that sort of thing. And that could be an extended consult, so book them in for a double period of time. What I find with rural folk is that they're much more likely to talk to somebody that they know or that they've already begun to establish a relationship with, rather than saying, oh, I think you've got a problem, go over there and see that person, in which case that never ever happens. And the other thing, of course, is to work with the other people that we know may already have those contacts with that group. So in Raglan we did a lot of work in the community following a suicide cluster that we had there in 2012 to look at how the community was connected and who was working within the area of suicide prevention. And there certainly are some rural workers out there who have quite a lot of experience in
So are they health workers
people.
or?
Well, not always. So some of them will be like the Rural Support Trust workers, but others are sort of counsellors who come from a rural background who have a particular interest in helping rural people and who can speak the language. A lot of it is about speaking the right language and using concepts that are actually relevant to that person.
Sometimes people aren't depressed that kill themselves.
No, absolutely. No.
So the signs then, are there differences between the two? I mean,
so the people with depression are actually much more easy to manage.
That's right. That's right.
Yeah, because you do get some signs. You get some signs beforehand, and as long as you actually ask, and I think that's the main thing that I would really encourage people to do is don't be afraid of asking. People are usually really, really relieved if you ask those questions. I would usually start off. Have you thought about ending your life? And if you have thought about ending your life, have you made any plans? And just going into details about things. Obviously, the more plans and details you get, the more at risk that person is, and they would need immediate help. But early on, if you get somebody early on, they'll often say, "Oh, well, I have thought about it." And then I'd say, well, have you made any plans? And they would say no. And I'd say, well, what stopped you? So then you're starting to look for all the reinforcing factors that are actually keeping them still here and trying to build upon those and build the support around them.
So what about the other people then that don't show signs of depression?
So yes, I have come across that, and that's really complex because a lot of it has to do with impulsiveness as well. So it's sometimes a really impulsive decision. And the other thing is if they really are suicidal, they often won't tell you.
Yes.
Because they have some kind of insight that you would try and prevent them.
Yes.
Yeah. And there's often when people actually get to the point that they've decided that's definitely what they're going to do, they do sometimes seem to be a bit less agitated because they've actually made a decision about what they're going to do. So
Right.
sometimes they seem quite calm.
So the mood's lifted almost as well.
The mood is often lifted.
Yes.
And sometimes that can be a few days before they actually go ahead with the suicide. So in that case, you are looking for other evidence. So things like so you'll come back to your normal sort of risks thing, like have they ever had a suicide attempt before? Is there a family history of suicide? And what are all the other risk factors in that particular person?
Yeah. What are the legal things that you can do if you know that someone's, yes, I've got a plan, yes, I'm going to do it, and what can you do?
You section them under the Mental Health Act.
Right.
Yeah.
Okay.
Yeah. No two ways about
Yes,
it.
safety first.
Yeah. And in rural places, often you'll need to section them anyway to actually be able to get them in, because the crisis team, it's too much of a risk for the crisis team to come out and then that person decide they don't want to have help anymore and they just up and leave, and then you've got the police looking after them, looking for them as well.
You spoke about suicide clusters because you had some clusters in Raglan.
So in our particular scenario, we had a cluster, not contagion.
Okay.
There was none of the people who died by suicide had actually seemed to have been influenced by any of the others.
Right.
There is actually an organisation called CASA, who come into areas where there has been a cluster, and they're specifically looking for contagion and how to prevent that. For example, in Kershaw, where there definitely was a cluster which has some contagion around suicide in young people. So they'll go and do work in education in schools and try to help the community that way. In our case, we didn't want there to be any contagion, any more contagion, so we didn't want there to be an ongoing thing of suicide within our community. So that's when we worked together within the community to increase the level of mental health literacy, really, within the community. I mean, that's really what we were doing. And we did that by educating people about mental illness through a workshop called Mental Health 101, and also by doing ASSIST training, which is Applied Suicide Intervention training, which is a 2-day workshop, and it's delivered by Lifeline, and we gave it to whoever wanted it within the community. Absolutely anybody. It was completely open.
So that would be interesting, who would turn up?
It was fantastic who turned up. There was a really huge cross-section of the community, from quite young to elderly, Māori, non-Māori, and lots of people within the community who were like the aunties of the community.
Yes.
Yeah. And you know, we had men and women, obviously generally more women than men came to it, but we've trained about 60 people within the community on the ASSIST programme.
I've heard of programs. I was Dr. Tom and his ambulance round, and hearing about them having community meetings for men, for rural men.
Yeah.
But then working out who's not at those meetings and then visiting those, because it's almost like the worried well. So those that want help and assistance will get help and assistance, but those that don't won't.
Yeah.
So how do you get to those? And I suppose you just explained how you do that. It's the aunties. It's the
aunties. It's almost like putting roots throughout the whole of the community. And I mean, for our community particularly, we had a number of men in their 40s die by suicide within our cluster. And most of those are in the surfing group within our community. So in fact, the men actually formed their own group. I mean, it wasn't like a group for mental illness. It was the surfers coming together.
What about Beating the Blues program? Is the John Kerwin thing? Has that helped?
So yes, we do utilise that programme. I think that what John Kerwin's done has been about raising the profile of asking about mental illness in men, and we actually have had men come in saying, I saw John Kerwin on TV saying, if I felt like this, I should come in, so I've come. You know, it's basically as basic as that.
Yeah.
And so that's been really useful. Some of them find the journal useful, some of them don't. On the whole, I think that we still find that the face-to-face stuff is actually really important. But in terms of getting people in and getting people looking for help, that has been an incredibly helpful thing.
How else? What's the next step for rural communities? Is there another step that we can do? I mean, starting to talk about it has been a really good thing. Is it part of a routine question that practice nurses and GPs are doing now as a matter of course?
Well, we are doing more health screening, as you know, within practice consultations, and things like asking about alcohol. Those sorts of questions often can take you down that route anyway. I'm not sure that we should be asking everybody who comes in whether they're going to kill themselves or not if they've come because they've cut their finger, because they may then not actually come at all.
Right.
But I do think we should be asking them about their lives, actually, and how things are going in their lives, and really trying to form those connections. So I think it's really, as we heard with John Burton's talk this morning, I mean, it's really easy to lose the central thread that is the essence of general practice, which is the relationship. And it doesn't matter whether you're a GP or a nurse or a medical centre assistant, whoever you are, the most important thing that you can do for that person is form a relationship with them. And from there, everything else comes on. So I think keep going with the relationship. I think that the connectedness within the community is really important, and knowing exactly how you can put help around somebody that might be accessible for them. Knowing where the informal hubs are, so like your coffee shop hubs and your surfing hubs, and knowing how to connect people within a community so that they can feel cared for.
Good positive message. Thank you very much.
Absolutely. Yeah. Thank you very much.
Thank you.